There you are, Judith. Thank you. Hi.
Hello. Sorry, I was just in another meeting.
No problem at all. We really appreciate you giving up some time for this webinar today. I know we've got a really interested and engaged audience. So I've kind of opened the webinar and acknowledged that we're coming to most of us here on Whadjuk Noongar country. And I want to introduce you all to Associate Professor Judith Lacey. She's the Head of Supportive Care and Integrative Oncology at Chris O'Brien Lifehouse. She's a senior specialist at St George Private Hospital. You can correct
Oh,
any
I'm
of this if
not.
it's updated. No,
No
not
longer.
anymore.
Just at
Okay, no longer.
Lifehouse. Yeah.
Okay, just Lifehouse. She's a thought leader and a very prolific researcher and someone that I greatly respect. We look to your work a lot for what we do here at Breast Cancer Care WA. So maybe I'll let you take over then and you can tell us more about yourself, your work, and this fascinating topic.
That's great. And are you recording this?
Yes, it is
Great.
being
Okay.
recorded.
So let me just see if I can share the screen, which is what I'm trying to do at the moment. Maybe I'm on the wrong screen for it. Okay. Um, I have a lot of things open, so let's see if I'm sharing the right screen because that's tell me if I'm sharing a screen that ah, uh, shit.
That's
Sorry.
all right. Take your time. We're
Is anything
grounded, we're
sharing? Is that
breathing.
sharing?
That is sharing, yes.
Beautiful, beautiful. So I can't see you, but I can see my screen, and I apologize that I am just a few minutes late. I've just surprised, VIP guests, and it's always really important that we showcase what we do in cancer care. And I've just finished a big clinic. So everyone in the audience are cancer patients, is that right? Living with breast cancer?
Yes, people who have had breast cancer. There may be some health professionals and also possibly a couple of family caregivers, support people
Okay,
too.
great. So I was asked to talk about evidence-based integrative oncology in breast cancer and also talking about medicinal cannabis as well. And so I've woven them together into this talk. So my title now is I'm the Director of Supportive Care and Integrative Oncology at Chris O'Brien Lifehouse. I couldn't work in too many places. I'm also involved on the International Board of Integrative Oncology and have been very active nationally as well. Now, to just set the scene, we're very, very fortunate in our centre at Chris O'Brien Lifehouse as we have the most comprehensive integrative oncology service in Australia. We're also now a mask centre of excellence in supportive cancer care. And so our role is to support people from the time of diagnosis all the way through to live well and thrive with cancer and beyond cancer. And for the last 10 years, I've been running this service, and the hospital is only 12 years old. And we have therapists that include exercise physiology, we've got a gym, acupuncture, yoga, and my slides are going to do their own timing, so they're going to jump all over the place. And we embed research into our care. And we see about 1,400 people a month. So we're busy. I'm going to start though with a case of one of my patients who's allowed me to share her story to really set the scene of the sort of people that we see and particularly focus on breast cancer. And so this is a typical patient of mine, breast cancer, 38-year-old woman, works in the fire department. She's fit, she's active, she doesn't have any kids. She's keen to preserve her fertility. She just hasn't got round to having kids yet. And then she was diagnosed, she felt a lump and was diagnosed with an estrogen positive progesterone negative, HER2 negative, large, 3 centimetre, the 30 millimetre intraductal left breast cancer. The Ki-67 was high, which meant it had a high rate of turnover, so it was quite aggressive cancer, and 2 of the 14 lymph nodes were positive. She wasn't BRCA positive. And so she went on to have what's called neoadjuvant dose dense chemotherapy, which is chemotherapy upfront to shrink the cancer, and then underwent a surgical lumpectomy. So she had AC, Adriamycin, AC-based chemotherapy, the red devil, is that what you call it? And then 12 weeks of paclitaxel. She had excellent response. The tumor shrunk down. She had the lump resected, the lymph nodes taken out of her axilla, and didn't have any residual disease. She had radiotherapy, chose not to have a reconstruction. She was started on Zoladex to preserve her ovarian function because she was still ambivalent about having kids, and she went on to letrozole and denosumab for treatment, so hormone therapy and bone supporting treatment. She came to see me initially after her first cycle of treatment. So this is common, and this is the preferred that I see people from the time of diagnosis. And I keep seeing her even to today, and this is years ago now. So her focus initially was how do I stay well on my treatment? What else can I do to stay well? How do I manage the toxicity and the side effects of treatment, the impact of being thrown into menopause, and improve my long-term and short-term outcome? And we continued to have a lot of discussions over this time. So I started the consultation as I do with an approach to the integrative oncology consultation. Increasingly, there are more and more people around the world doing this work, and in fact, we published how to provide this consultation recently as an international group last year, and we're publishing another paper on how to set up a service. And so when I take a history, I want to know everything about the person that's in my room. What's the current treatment? What are their goals of care? I use patient-reported outcome measures. We all do in our service to understand what are the main symptoms that are concerned at this point in time, on this day, this time. What's the cancer history? What's the family history? What have you done in the past to exercise, to stay well, to cope with distress? What physical activity, nutrition, what diet you eat, what medications you're taking, what natural products you're taking or interested in taking, emotional health, well-being, sleep concerns, development, and then we develop a multidisciplinary plan of care. That's the standard consultation that I do. And so this consultation enables me to identify, and any of us working in integrative oncology, I've got a superb nurse practitioner that works, a nurse consultant that works with me, to say, well, how do we develop a whole person approach to you living with cancer using this biopsychosocial model and this expanded toolbox that includes all of these therapies that we have available: yoga, qigong, music and art therapy, exercise, mindfulness meditation, medicinal cannabis, psycho-oncology, diet changes, lymphedema, assessment, management, herb supplements, and occupational therapy. And this is becoming the mainstay of integrative oncology and supportive cancer care worldwide. Australia's lagging, but we'll get there. For breast cancer patients, there are really specific symptoms that are commonly presented. And so we've been looking specifically at our breast cancer patients and building programs around that cohort of patients, about 30% of the people that we see. Say, what if these symptoms occur in clusters? They occur together. How can we reduce treating just the symptom and not treating the whole person, and that interaction between the symptom clusters? So the example is pain and sleep disturbances occur in cluster. Hot flushes can impact on your sleep, neuropathy and sleep disturbances and pain and chemo fog and fatigue often all interrelate. And what treatments do we have that can treat all of these symptoms, such as acupuncture, medicinal cannabis, exercise, and other treatments to reduce the impact of cancer and cancer treatments on the whole person? And so we developed a program based on this called for people receiving neoadjuvant chemotherapy, thanks to some donors. And we developed what's called a proactive management of people with receiving what's called neoadjuvant chemotherapy, such as my patient, and streamlining the approach. And we published the protocol, and we also interviewed all of the patients that have gone through breast cancer treatment to say what was missing, what was good in generally your support, and how can we improve that moving forward. And that piece is coming out very soon, just accepted for publication. And then we built a program based on our understanding from our patients. And as you know, breast cancer treatment keeps changing on a weekly basis. Now, if you've got triple negative breast cancer, you have immunotherapy up front if it's stage 2 or more, while when we initially designed the study, that wasn't the case. So treatment is forever changing. We need to be very agile. But despite that, the general structure looks something like this. We enrolled people from the time of after within their first treatment of chemotherapy or chemo and immunotherapy, and then got them assessed, had a holistic consultation like the one I showed you with the nurse consultant, and then developed a personalized program that included twice a week exercise program, understanding body measurements, diet, education, and other therapies. And we based the other therapies on the evidence too, and there are a whole lot of references that go with this. So if you've got pain, is acupuncture, massage, and mindfulness may be recommended versus fatigue, where yoga and acupuncture, anxiety, nausea, neuropathy, and so on. And identifying the symptoms when they occur using patient-reported outcome measures, checking in on the people, and then working out what therapy is going to be good at what time for what person. And this is called this multidisciplinary integrative approach. And so if you look at a typical person having breast cancer, as I said, all of this keeps changing. But for this patient, she had surgery to identify the cancer, but then she went on to have further definitive surgery. She had dose-dense AC, then paclitaxel. Some people will have Herceptin. She had hormone treatment for ovarian preservation, followed by, so this is the typical approach that most people will have. And then we add in what else can we do, which is up the top there, to support the whole person at different stages of disease. And how do we do this in an evidence-informed and evidence-based way? And we do that by having a good team and understanding what goes on for people, understanding the evidence, identifying people's personalized concerns, and applying that evidence to build programs and having the right people in your team with the skills and understanding to provide that care, and using the screening tools, coming together as a team once a week to discuss complex or new patients, and then working out what referrals to make and how to build a program and how to measure the benefit of that treatment. So that's our standard of care, and it's been our standard of care now for 10 years. But let's have a look a little bit more closely. And I really like this diagram. This is from 2021, the evidence-based approach for managing side effects of endocrine therapies, of what happens to cancer patients after they've had their acute treatment and they go on to endocrine therapy. And we know that there are a lot of side effects from endocrine therapies, and the oncologist will only see you once a year, sometimes once every 6 months, but they won't be seeing you every few weeks to check in on how your side effects are going. So the assumption is that you get either care elsewhere or you just don't get side effects. But we do know we do know that's not true. And so we're looking at what are the main side effects of hormone therapy. And so if you look at in the red, you'll see, or the orangey color, you see hot flushes, and you can see in that outer circle there are different therapies that you can offer for hot flushes, including acupuncture, including drugs, including yoga and mindfulness, and a cold pad pillow, and clonidine. There are different drugs as well. And then what about cancer-related fatigue? The most common symptom that people experience, particularly now with the CDK4/6 inhibitors, abemaciclib, we know that people get a huge amount of fatigue when they're on this for 2 years afterwards. Fatigue and diarrhea are the main toxicities. What evidence do we have to recommend certain integrative therapies such as acupuncture, exercise? Exercise is in the dark purple. We've got high level evidence to recommend exercise for treatment, and we've published those guidelines. Similarly, with musculoskeletal symptoms, people can get joint pain during treatment from paclitaxel, joint pain from aromatase inhibitors, and also sexual function dysfunction. How do you manage that? And weight gain. And so it's building a program that includes some of these therapies. So I come back to say, well, what are these therapies? So one of them is yoga. So yoga for management of cancer-related toxicities, including those hormone-related toxicities, been well studied. And Karen Mustian, who I did a podcast with her recently. She's been very involved in the guideline development. Talked about developed a program called the YOCAS program, looking at yoga for different symptoms related to cancer, to breast cancer, such as sleep disturbance, cancer-related fatigue, cognitive impairment, that cluster of symptoms, as you can see, and we're still working out what dose, what type of treatment. And then one of my PhD students, Maria Lopez, just had published the value of the benefits, potential benefits of yoga for women after breast cancer treatment, and it was ovarian cancer as well, for managing the psychological impact and distress of cancer treatment and having a breast cancer diagnosis. So another one of the therapies when we talk about common side effects, and we've got a lot of guidelines that we follow and algorithms to recommend certain treatments. And one of those is the pain guidelines. And the pain guideline recommends that for people who are on aromatase inhibitors who have that dreadful joint pain, that bilateral joint pain, acupuncture can be beneficial and we should be recommending it. And similarly, yoga may be beneficial. And so how do you there's more evidence for acupuncture. How do we incorporate this into people's standard of care? How many treatments do you need? Who needs to provide this? And so studies have been done in this space, and this is the work of Jun Mao and others, looking at really good quality studies to show the benefit of acupuncture, 6 weeks of acupuncture at certain points, showing a significant benefit compared to either waitlist or sham for improving joint pain in people on aromatase inhibitors. We want people to stay on these drugs. I talked about letrozole and similar drugs. But I'm going to now jump. So there's a lot. I can talk for many hours about this. I do for a living. I've spoken for 6 hours already today about the benefit of all of these treatments. But then we go, okay, but what else can we do? And this is coming back to our case. So I'm going to just talk about the role of medicinal cannabis. That was something that you guys wanted me to talk about. So I'm going to go back to this woman, our firefighter. And she had acupuncture for her fatigue and her peripheral neuropathy. It did help, and it helped her fatigue. We know that acupuncture can help fatigue, and it can help for her peripheral neuropathy. And we've just completed a study in that space, but it didn't completely improve her joint pain despite 6 sessions. Because the good thing about acupuncture, you can treat multiple symptoms at the same time. And my new PhD student will be looking at treating the symptom clusters for people on in breast cancer survivorship space with acupuncture. The exercise, she was exercising regularly. We've got a gym, the exercise physiologist in the gym. Came twice a week. She did yoga once a week. She started our mindfulness meditation course. Her vitamin D was low. We managed to get that up. Magnesium can help with joint pain. Took magnesium supplements. We talked about the anti-inflammatory diet. The anti-inflammatory diet is a very specific, very comprehensive diet that is very easy to implement, really similar to the Mediterranean diet with a few extra anti-inflammatory foods. And we also look at the impact of the gut microbiome on other symptoms and looked at what is still impacting her and what else do we need to improve. And so we came to the fact that despite everything else being okay, she's back at work, she still had quite significant aromatase inhibitor related joint pain that was now impacting on her quality of life, and her sleep disturbance was really quite severe, and this led her to feeling fatigue and anxiety. But she could get off to sleep, but she couldn't get a decent, good quality night's sleep. So we said, well, now we've got refractory symptoms. What are the potential benefits of medicinal cannabis? One limitation, I don't know about Western Australia, one limitation in New South Wales is that you can't drive with medicinal cannabis. if it has THC. So she says, I'm happy not to drive. I'm not in an active position in the fire department. I'm behind the desk. They're happy for me not to drive, and I can stay on hormone treatment and I can have a THC-containing product. We cleared that all with work. And so I prescribed a medicinal cannabis product. Now, I have to put a caveat here. I have been prescribing cannabis since 2016 for cancer patients, cancer-related symptoms. I started off having one product to prescribe. I now have 1,600. So when I have so many products to choose from, I need to simplify it, particularly in the cancer space, because there's a lot of other stuff going on. And so I am presenting a very simplified view of how I use cannabis in cancer care. And for this patient, um, while she wasn't driving, didn't need to drive, it was fine to just improve her symptoms and her sleep. We started a one-to-one whole plant THC and CBD cannabis oil, starting at a low dose. It was 10 milligrams per mil, starting on 0.25 mils, which is 2.5 milligram equivalent, starting at a very low dose and increasing it. And that really significantly improved her sleep and her joint pain. She had a very small dose in the daytime sometimes, and that was profoundly helpful. It also seemed to help her anxiety. So it helped her pain, her sleep, and her anxiety, but she couldn't drive with it. So we said, okay, you're going back to work, you're going to start driving, because the impact of not driving impacts on your quality of life, doesn't it? It can cause social isolation. Driving is really important for many people. You can drive without THC, and increasingly I've got access to more products. So a CBD product that has anti-inflammatory benefits, such as one that may have CBDA or CBC or CBG, other phytocannabinoids. Um, we rotated to something that she could drive with for her joint pain, and it seemed to help her joint pain significantly. Didn't help her sleep much. So it's going back to what else can you do to improve your sleep? So we talked about exercising at the right time, returning to yoga, returning to meditation, and how to combine these therapies while improving her quality of life and keeping her on medication. And so she ended up on 100 milligram per mil CBD, half a mil twice a day. And the cognitive fog was addressed by improving her exercise, regular yoga, and improving her sleep. I talk about cannabis, and I can talk about cannabis for a long time, but I'm just going to go through a few very short slides on medicinal cannabis. And cannabis, as you may or may not know, since the 1980s, we've discovered that we have a full endocannabinoid system in our bodies. Our body has endocannabinoid receptors, particularly in the brain and in the midline, right throughout your central nervous system, but also in the periphery. You produce endocannabinoids, which are neurotransmitters such as anandamide, which is also called the bliss hormone, or 2-AG, or AEA or OEA. Anyway, you produce a lot of these endocannabinoids, and their job is to keep everything regulated, keep your body in homeostasis. We also know that there's something called phytocannabinoids. Cannabis has been around for centuries and is very much a part of traditional medicines in many cultures around the world. And this is the plant that acts on those same receptors. So we talk about some of the 144 different cannabinoids, such as THC, CBD, THCV, THCA, CBDA, and so on. And then we also have what's called the terpenes, which are all things that make cannabis smell like weed, like pine, myrcene and linalool and pinene and other terpenes that give things their smell but also have medicinal value. And so increasingly we prescribe according to the minor cannabinoids and the terpene profile. And it is far more complex. The more you learn, the less you know. So let's go back to our typical breast cancer patient, and we can go back to this concept of symptom clusters. Women with metastatic and non-metastatic cancer increasingly are interested in cannabis if they have multiple symptoms occurring at one stage, and often have insomnia as well. And we know that choosing the right product can improve their ability to stay on aromatase inhibitors or other treatment. We also know that cannabis has been shown to be very, very helpful, and my slides have all gone a bit funny there, for refractory chemotherapy-related nausea. And in fact, one of the first government studies that were conducted in Australia was conducted in our hospital by Peter Grimmerson, one of our medical oncologists, and a whole group of medical oncologists, and actually showed that cannabis was beneficial, and actually another paper's coming out saying that it's also cost effective for people with difficult chemotherapy related nausea that some people definitely develop on treatment. And so the question is it mainstream? Is it standard of care? And so increasingly people are being prescribed cannabis more willingly in the cancer space. You have to also realize that in the cancer space, in the cannabis space, there are a lot of 20-year-old young men with sudden anxiety disorders wanting lots of flower, and it's really messing up the name of medicinal cannabis. So um, I try and not prescribe for non-cancer patients. In fact, I don't. We also did a review of the population that we see and how you combine all of these therapies together. And we go back to those patient-reported outcome measures, which were very helpful for when I'm using medicinal cannabis, but also identifying that our service provides lymphedema therapy, acupuncture, my holistic integrative oncology program, medical and nursing consultation, massage, yoga, exercise, reflexology, and other treatments. And it's coming together and working together. So if we just looked at 1,125 occasions of service of breast cancer patients as a snapshot a couple of years ago, saw that the most common reason people are seeing us are fatigue, sleep issues, reduced well-being, neuropathy, and pain. And that's only those with moderate to severe. So we know that people have symptoms and those symptoms continue. Now I'll come back to cannabis again on this slide, but I didn't realize I put this slide here, but that's what it looks like. The male does a little bit of the work, the woman is the female plant is the medicinal plant. And I'm coming back to cannabis again with my different cannabinoids and what they do and the terpenes. Sorry, I knew I had those slides somewhere, but I couldn't find them. One more comment on cannabis is that it comes in different forms. So there's the plant, the flower. Flowers everywhere at the moment because the industry's a bit messy, but smoking works quickly. You can get all the benefits of the terpenes. There's a much more variety. It can be, but smoking irritates your lungs and can increase your risk of lung cancer and toxicity. So vaporizing is the recommendation. It can be eaten, it can be juiced, it can be as tinctures. And we're not quite sure about the benefits of suppositories, but some patients with endometrial issues, vaginal pain, have found some topical vaginal treatments quite interesting and helpful. So that's cannabis. That's generally the approach. And I'm just going to touch on a few common other symptoms that our breast cancer patients experience. And one of them is cancer-related cognitive impairment. You know, it's really amazing when you look at these statistics, and this is from a paper back from 2017, but I don't think the numbers have changed that much, that 30 to 40% of people from the time of diagnosis actually start developing a cognitive impairment. You can't even call it chemo fog because they haven't even started chemo yet, that fogginess. During treatment, it jumps up to 40 to 80%, and into survivorship, this can continue for greater than 1 year. 35% are still experiencing it, and post chemo you can see those statistics. So it's a real problem, and it's a real problem that doesn't just happen with breast cancer. So breast cancer is the most common reason that people, you're also thrown into menopause or menopausal symptoms plus side effects of the other treatments, are more common and the most studied. But you can see on that list on one side of the slide that there are other cancers and other treatments that also cause brain fog. And when somebody has a brain fog or a cognitive impairment, a lot goes through our heads as what are the potential causes of this, and it's multiple causes. So if somebody has vascular ischemic heart disease or diabetes or other comorbidities, there are certain things we need to be able to treat. reduce inflammation, and then there's a lot of different management options for that person. And I go back to what else can we do to improve someone's well-being? If you don't sleep well, your fog doesn't lift. You feel like you're in that chronic state of jet lag. So we always look at, is there a mechanism? Is there something reversible that can improve someone's outcome? Like their sleep, are they anemic? Are they thyroid dysfunction, poorly controlled diabetes, whatever? Is it a drug they're taking? We address the symptoms and the cluster of symptoms. We take this holistic approach and we look at the evidence base of adding exercise plus acupuncture, mindfulness, yoga, behavioral brain training, and looking at how do you manage that to address the whole person and the person sitting in front of you. And then in our research program, we continue to look at all the gaps. And you can see from this list here that the potential therapies can also potentially include some herbs and supplements like ginkgo and lion's mane and ginseng, and there's still a lot of work in that space. Similarly, sleep disturbances are very, very common. And we just published recently a paper led by Carolyn E. and Bronda Kozłowski and myself, looking at sleep disturbances in people and what the level of evidence for lifestyle management and exercise is very high on the list, but there's evidence to suggest yoga, exercise, medicinal cannabis for sleep disturbance is a possibility for some, not enough studies yet. Anecdotally, my patients seem to get really good quality sleep with certain medicinal cannabis products, qigong, sleep training, relaxation. And treatment itself also can impact on your mood. And to say that it doesn't means that maybe you're not really a present person. We know that a lot of women during and after a breast cancer diagnosis struggle with anxiety, depression, distress, coping, fear of recurrence, and that can happen. And how do we best personalize treatment using mindfulness, yoga therapy, exercise, lifestyle change, herbs and supplements, and a combination and a personalized approach, and listening to people. You know, listening makes a huge difference, I think, for anxiety and depression. And we've recently run a mindfulness program for people living with treatable but not curable cancer. That group of people living with metastatic, treatable but not curable cancer, and we ran a mindfulness-based program based on MBSR, which is mindfulness-based stress reduction, for coping with the uncertainty of and how to live well in that space. Fantastic results. And finally, what you eat matters. And what you eat really matters. And if the dietitian says what you eat doesn't matter, then the dietitian hasn't read the literature. And this is an ongoing concern about the value add of eating well. And different diets make a difference. So if we say the Mediterranean anti-inflammatory diet is great, do you really need refined sugars in your diet? Do you need to have dairy? And what about your gut microbiome? The bacteria that live in your gut impact on all of you and may actually impact on the cancer itself, particularly with triple negative breast cancer, with other cancers. Dysbiosis of the gut may definitely can impact on response to immunotherapy in cancers such as skin and lung cancer. There haven't been studies yet in triple negative breast cancer, but the assumption is that you get a better response to immunotherapy if your gut health is better and you have more diversity of the bacteria in your gut. So that's a really interesting space that we're all working in. And so when you're looking at discussing diet, it's not enough to say eat what you want, you'll be fine. People put on weight during treatment. People lose weight during a diagnosis. What diet matters? If you're going on a specific diet, do you get your balance of food that matters? If you decide to go on a intermittent fasting, how do you balance that and make sure you get all the nutrients you need, your gut microbiome, and then everything needs to be individualized. And so I'm going to stop there to allow a few minutes for questions and answers because, as I said, I can talk about this topic for a very long time. Thank you.
Thank you so much, Judith. I've got lots of questions. And for the people listening in, if you haven't already discovered, there is an open Q&A box there. So I can see one here. I'll read it out to you if you like, Judith. So a participant says, post-operative physiotherapy is strongly supported by evidence, yet it's still not routinely embedded in breast cancer care pathways. From your perspective, what are the reasons for this gap? And how can the sector shift toward more consistent integration?
Aussie, hello. So Aussie sees a lot of our patients and is an incredible lymphedema therapist and a great advocate for this. I think it depends on the surgeon. It depends on the type of surgery that's been had. And so people who've had an abdominal flap and had a reconstruction are very different from people who've had a lumpectomy, who've had an axillary clearance. So every surgeon said, well, when can you start exercising? So it needs to be personalized, but definitely we're seeing people sooner rather than later nowadays because people have other parts of their body besides their arms and their chest that they can continue to exercise. And so my recommendation is always see a accredited exercise physiologist or physiotherapy that understands cancer and understands your surgery and has access and is a good communicator with your medical team. The second question that Orsi asked is, what guidance would you offer allied health clinicians supporting breast cancer patients who are interested in medicinal cannabis, particularly around communication safety and coordinating with their broader oncology team? Look, our oncology team are very cannabis, they're very open to us prescribing cannabis. It's about, are they on a clinical trial, driving the safety around it and the reason to be on taking cannabis. So I guide the patient and I document well and I send letters to the practitioners. Unfortunately, we have these very unusual medicinal cannabis clinics right throughout Australia that don't necessarily communicate.
Yes, I suppose that's one of my big questions. I've kind of been exposed to that medicinal cannabis world quite a bit. I took a trip to Thailand and checked out how they're doing things there. And I can see, and you've hinted at this, that it's quite open to misuse and open to, corruption at all levels, I suppose. Do you ever see any negative effects? Do you ever see any cancer survivors or patients who are kind of misusing it?
Um, that's a really good question. I see, I look after people from all cancers. Uh, Very occasionally, no, so mostly most of my patients, and I actually presented a study the other day that pharmacists did of examining my patients to see how their adherence and their use, do they misuse it, the benefits, which has recently been published, and that really showed that people who find it helpful stay on it and they work out their dose at the right time. There are, there are occasionally younger people that are, or other people that aren't so young, that are using it initially for their symptom management and then continue to use it or abuse it. But I don't see that a lot. And so when I don't see it a lot, it is maybe I'm not I am aware. I'm aware that my young patient who finished his chemotherapy for his sarcoma, who found a flower that was vaporized, very, very helpful to get him through his chemo because he had severe chemotherapy related nausea and vomiting. And then he continued to use his leftover flower for partying. So occasionally, but not in my world. So I'm very fortunate. I am very careful of who I prescribe for. People who are heavy users, I don't prescribe for. People who are using other drugs, I don't prescribe.
Sounds responsible.
I'm
Responsible use,
responsible. I work
responsible
for the
prescribe.
government.
There is another question in the Q&A
Yeah.
about who can actually prescribe the cannabis. They say they've got a visiting oncology service, so link back into the GPs for supportive medication scripts, but not all GPs are happy or able to prescribe cannabis.
So, anonymous attendee, the answer to that question is that Google it. There are medicinal cannabis clinics, and there are some more reputable than others that do telehealth. And so rural and remote patients have very good access to cannabis. I don't know about Western Australia, but in New South Wales, Tasmania, Victoria, Queensland, you have one of the best cannabis companies, one of the first, Little Green Farmer. The first cannabis that I actually prescribed came from a pharmacy in Western Australia. Um, you, GPs aren't comfortable. GPs are being trained. It's tricky, but there are ways of being prescribed. The question is, are you getting good advice when you're being prescribed? And the answer is probably not. So you need to go to a reputable company.
Yes. So Little Green Farmer might be a good starting point for people who are searching online because, yes, I can attest to there are some not so reputable providers, and it's an incredible shift in the landscape. But I think the restrictions are coming in now. I think the pendulum swung, like you can just sort of order it and it arrives at your house without much, checks and balances. But now it's coming back to a little bit, safer prescribing, I think.
Yeah, because people are losing their licenses. A lot of doctors have lost their licenses for bad prescribing.
Yeah.
Lazy. Yeah.
Yes, there's a lot of money in these things as well, I
Oh,
guess.
yeah.
There's that aspect. I had another question about the herbs and supplements. So that's part of my background, and I've studied all of these things, but I stopped using them because of the risk of interactions with conventional treatment. You had listed a few, some ginseng, some ginkgo for cognitive impairment. Do you see many risks of interaction with people taking herbs and natural supplements?
Interactions, there are a lot of interactions. I mean, we have if you look at ribociclib or abemaciclib, it interacts with a hell of a lot of things. And so the most important thing with every herb and supplement is just because it's natural, it's not okay. So I work very closely with our pharmacists, and the most important thing is to work closely with your pharmacist, send a list of the treatment that you're on and a list of the herbs and supplements that you're interested in taking or you're taking, and we look for the interactions and the safety. And we have superb databases now that can actually spit out a recommendation from that, and then work with a doctor or a senior pharmacist that is comfortable in going through that with you.
Yeah. Yeah, because they can change the way people metabolize their conventional medications and all of
It
that,
can
can't they?
really impact, it can make your treatment not work well.
Yeah,
It can make your treatment more toxic. So it is really important. I mean, the example even of turmeric, people say, oh, turmeric's fine, it's natural. Take a big dose of turmeric with some of your treatment, and your treatment may be less effective or more toxic. It can increase your risk of bleeding. So just because it's natural, it's not safe.
yeah.
Yeah.
There's another question there about the quality. Is there a difference in the quality of CBD oil dispensed?
The quality, well, it's not just CBD oil, it's cannabis oil, it's complex. Yes, there is, but the TGA, the Therapeutic Goods Administration, is very good at controlling what is brought into the country and the quality, but definitely some are better than others. Some taste foul, some don't. Some are um, but generally the quality is better than over the counter imported, picked up at the local markets cannabis oil.
Yeah. I think the TGA is an important thing to recognise when we're talking about
Huge.
supplements. Generally, if you're looking for those little labels, make sure it is Australian and that it is listed or registered because, yeah, the stuff you can buy online from other countries might not even be exactly what it says it is on the label.
So, yep. Should we go to the next question?
Go for it, Judith. Yes.
So the anti-inflammatory diet I really like, and you can Google this, Andrew Weil, Wiel or EIL, just look it up. I always get his back to front anti-inflammatory diet. It's an anti-inflammatory pyramid, and there are a lot of recipes related to that. There's also a superb website called Cancer Choices, And Cancer Choices is a um, the Cancer Choices is a very good resource for all the different diets, all the different herbs and supplements, what else you can do alongside of cancer care. It's an American website that puts in levels of evidence and guidance, and it's a very good one on breast cancer. When it comes to the anti-inflammatory diet, I think there is a section on the anti-inflammatory diet. Otherwise, go to Andrew Weil anti-inflammatory diet, and there's a very, very good reference. And there's also a book that you can get for free, an ebook called Cancer Fighting Kitchen. There, it's all very American, but American, it's fine. Um, when it comes to serious mental conditions and schizophrenia, so I just came back from the Clinical Oncology Society of Australia conference. It was combined with the International Psycho-Oncology Society group, and there was a brilliant talk on serious mental health conditions and how we actually manage people with serious mental health conditions, such as schizophrenia that may have cancer. Medicinal cannabis isn't something that you give to somebody with schizophrenia or psychosis in a hurry. You have to be very, very careful with people with established schizophrenia. And it's a tricky population and really important to get equity of access to cancer care for people living with serious mental illness.
Yeah. Got a couple more questions myself. I'm keeping an eye on that inbox as
Mm.
well. So you talked a bit about the gut microbiome, and I get the sense that food is our best way of increasing, the fiber to feed the different microbes. Is there any evidence that you're aware of for probiotics?
The more you learn about the gut microbiome, the more uncomfortable I am with just prescribing off-the-shelf probiotics. So I test people's gut microbiome, and when I test, I see, well, this person really needs this probiotic. This could really help. And these dietary changes, which are called prebiotics, there's something called symbiotics, there's something called postbiotics. The complexity, but the importance is that you look at what's going on in your gut, what probiotics does your body need that are going to be beneficial. There are certain probiotics that, very specific ones, that are good for bladder cancer patients receiving immunotherapy. And there's a study that increased the butyrate production. People who are taking a lot of probiotics, there's a risk that you could reduce the diversity of your gut microbiome. And if you reduce the diversity, you may have a poorer response to immunotherapy. So not more probiotics is not necessarily good. Taking more antibiotics is not good either. So if you're taking antibiotics, do you need a probiotic with the antibiotic? Probably. So it very I've just been asked to write a guidance piece for our hospital on probiotics because, everyone's saying, oh, can't I just take probiotics? What's wrong with them? But actually, your gut matters. And so you need to personalize what you take to what your body needs.
Fantastic information, Judith. One last question from me, if you've got time. You mentioned the mindfulness program for people living with advanced cancer, and I wondered if you'd published anything on that because we've done similar work here at Breast Cancer Care WA. We're interested in this space.
Yeah, and I actually we did it with you may have heard of and it's a plug for the group really, with a metastatic breast cancer action group that Andrea Smith was involved in our mindfulness program. No, we haven't published it because we didn't get the ethics in on time, so we will be in the future when we get some more funding for it. And we're just writing up our mindfulness online program for the general population. What we did find, though, in our pre and post review, that it really assisted people to live more fully and with less anxiety and cope with the uncertainty that a metastatic cancer diagnosis brings. And so the Metastatic Breast Cancer Action Group is amazing. And they do and so I think there is a lot of opportunity in that space.
Yes, we're really interested in that too. We'll have to talk further offline. Can you see those last couple of questions there?
Yep, and I am got a meeting soon. Can you recommend a gut biome test that we can access? Look, there are a lot. The one that I use is from a company called Microba. They keep changing their name. It was Microba, it was then Cobiome. They started off at the University of Queensland with Ian Fraser that developed the cancer of the cervix vaccine work. And it's a very comprehensive test, but you need a doctor to interpret it or a specialist referrer to refer. Um, there are lots of companies now entering into this space, and I have no shares in any company. But I did write a book chapter on it, and now I know nothing, so it's overwhelming. Thinking of bone health on hormone blockers and weight strength training, can creatine and protein powders be looked at? Protein powders, yes. Creatine is really interesting, isn't it? So bone health is essential. The Onero program, you should have all heard of the Onero program. Weight training, jumping around. There's a specific program for people with osteoporosis, osteopenia. Bone health is really important. Vitamin D levels are really essential. Protein for people, lean muscle mass is building up lean muscle mass is pretty important. Creatine can help with lean muscle mass. Need to look at the safety depending on your cancer and your treatment.
Yes, yes, it's all the rage. And I think these things, they come into the zeitgeist and people start taking them, and then we find out actually things that make muscles grow might make other things grow.
Exactly. And that's the concern with creatine in a few cancers. I'm just not sure with um, different breast cancers. Yeah.
Look, thank you so much. Associate Professor Judith Lacey, you are a wealth of knowledge. We're so appreciative of your time. This recording will be slightly edited because we started a bit at the beginning, and then it will be available. You're welcome to share it. Everyone participating is welcome to access it again. And yeah, we'll be in touch.
Thank
Thank you
you.
so
And
much.
I'm glad that there's interest in this space and it's been a privilege.
Thank you.
Okay, bye.
Bye.